what I'm going to do today, it's been interesting how much interest there has been in the case presentations and the discussion that it's stimulated, and so hopefully this will stimulate a little bit of discussion. But this isn't so much a case presentation as it really is a story, and it's a story about, I think, my journey as a sports medicine physician and perhaps sports cardiology as a discipline. And so the first thing I'm going to do is I'm going to take you back. And so this was some years ago. Lord of the Rings was in the theaters. Justin Timberlake and Britney Spears had just broken up, sadly. And Michael Jackson was hanging blanket over the edge of the railing over there. Does anybody remember or want to give me a guess about what year that was? Exactly. I heard 2002 out there. That's really good. This is 2002. And so this all started back in 2002, 15 years ago, and it was actually the very end of 2002 as New Year's Eve. And so I had a 21-year-old women's basketball player. She was at home. They had practice at 6 a.m. the next morning, so she wasn't doing anything bad that college students may sometimes do on New Year's Eve. She didn't feel well, so she went upstairs. She was accompanied by her roommate. While she was up there, she fell over and arrested. She fell onto the floor. Her roommates promptly moved her onto the bed to do CPR. And they did CPR until our EMS got there. And thankfully, we have a very quick response time in Seattle. She was in torsades and she was defibrillated. So sort of interestingly, about a month before, she had gone to the ER with substernal chest pain. And at that time, this was her ECG. And the ECG was read as normal. There's the read right there. And she was given a GI cocktail, which relieved her pain, and she went home. Now, this was her ECG when she went to the ER after she'd been defibrillated. And I can take that off there if you guys want to look at it. I know it's a little bit hard from the vantage point here, but it was really read as pretty much normal. She had an echocardiogram, which showed mild LV dysfunction. It was the day after her arrest, not surprising. She had a cardiac catheterization, which also showed some hypokinesis, no accessory pathways. And on the next day, January 3rd, she got this ECG right here. And so now we're getting to sort of a little bit more funny looking T waves perhaps. And it was read as normal, but this is the ECG that sort of she had a mildly prolonged, I mean, I wouldn't even call it prolonged, but at the time it was called prolonged QT. And she was given a diagnosis of long QT syndrome, and she got a defibrillator. Now, her family history, she didn't have any family history of sudden cardiac arrest or death. Her father and brother both had normal ECGs. Her mother had had one borderline ECG, and I don't know, I don't have that ECG or know how borderline it was, but she got that defibrillator. And so, this was a star basketball player. She was a great shooter, and she was sort of relegated to not doing much. However, her cardiovascular physician at the time said, you know, you can still play some recreational basketball. And so she was still out there playing, and she was playing some pretty intense recreational basketball. She was going over to Green Lake, which is an outdoor court here, where they have some pretty intense runs. She was playing at the IMA, mostly with guys and pretty intensely. And so after about a year and a half of not playing formal basketball and playing a lot of recreational basketball, she decided that she wanted a second opinion in terms of her condition and whether or not it would be advisable for her to play. And that is when I met Mike Ackerman. And so she went to the Mayo Clinic. He said, you know, you only had one ECG that had sort of a mildly prolonged QT. She happened to be on Cipro at the time because she had a catheter-associated urinary tract infection. He's like, you know, your arrest occurred at rest. You don't really have any family history. You're probably as likely to have another arrest at rest as well as exercise. So he's like, so I don't really think that you have long QT syndrome, and I think it is fine for you to play basketball at the college level. And so she was cleared to play, and so she came back. And I'm like, now what? Kayla and her family very nicely came and said, hey, Dr. Harmon, what do you think? We've got this opinion. I've got my institution cardiologist saying that I really don't think that's a good idea. He went and he reviewed the case. He talked with Mike Ackerman, and he's like, it's a difference of opinion. He was very reasonable. He's just like, I just don't think she should play. And so I thought that I should go to the UW and see what they thought. And so I went to the athletic director and I sort of explained the case to him. And what I was hoping was that they'd say, we don't want to take that risk. She can't play. But instead they said, whatever you think, Kim.
Nice.
Like, dang. Because I really sort of hoping to shift that decision. So this really sort of, caused a crisis. This is back in 2002. And Kayla was still playing basketball. The question, and she's, this case was highly publicized. She's okay with me talking about this. The really easy thing would have been to restrict her. That's what the guidelines said to do. But I talked a lot with Mike, and I really wanted to do the right thing. And I didn't want to do what was just easy. But at the same time, going against the guideline, I'd been in practice for maybe 4 years. I didn't know that much about sudden cardiac arrest or death or sports cardiology. Put me at some personal medical legal risk, and you begin to think, gosh, is that fair to do my family? There's also some concerns about playing with the ICD. It was not only the underlying disease, but the fact that she had this ICD. Would there be damage to the ICD just in the course of playing basketball? Would there be a lead fracture? One of the things that they talked about was that the ICD may not terminate a rhythm in the setting of intense exercise, like she might be playing at basketball, or would she have a VFib storm and just get shocked and shocked and shocked, and the rhythm never terminate and have her die right there. So these were all things that I was pretty concerned about. And so I thought a lot about this. I went and I looked at the guidelines again and again and again, and those were very clear. And I made phone calls to experts and people that had written the guidelines, and they all told me that she should not play, except for Mike. I went to a sports medicine conference on a sports ethics conference. One of the leaders in sports cardiology was there, and I presented the case to him, and he told me that if I let her play, I was an ethical idiot, I think was the exact words that he used. And so this is sort of the setting that I had to deal with. And so what did I decide? I decided to let her go ahead and play. And so this gets to the question that was asked about waivers a little bit. Last night I was looking sort of at some of the things in the paper. Kayla said, I want to make it very clear that I realize that basketball is just a game. But to me, it is more than that. It is a sport I love, the sport I've invested my life in, and the sport that allows me to live out my dreams. So basketball really was her oxygen. And this is what I said in the paper. I said, and maybe like Aaron, I said, the exact amount of risk can't be quantified. Kayla understands that she is in increased risk, and the university is supporting her right to make the informed choice to play. So what happened? Well, actually, getting back to the waiver issue, I didn't put this in there. We actually did have her sign a waiver. It was a very medical, legal, sort of thick thing. I didn't understand it when I read it. I'm sure that Kayla or her parents did not understand it. But the other thing that we did, and this was the suggestion of one of the leaders in the sports medicine field, Stan Herring, he said videotape them. Because it's one thing, with a dead patient and a crying parent saying, I didn't know what I was signing. And it's another thing to have a video of somebody saying, I understand that I might die doing this, and I still want to do it. I understand that my kid might die doing this, and it's okay. And so we also videotaped an attestation to those words. So after about a year and a half playing basketball, we were playing actually UCLA. This is USC here, but we were playing UCLA. During a timeout, her defibrillator went off. And Kayla got this look on her face. I knew immediately. I grabbed her. The athletic trainer grabbed her. We walked out into the hall. And while we were walking her out to the hall, it went off again. And Kayla was sitting there saying, give my mom, I'm gonna die, I'm gonna die, I'm gonna die. And I said, Kayla, calm down, because I'm thinking she's going to, get really adrenaline here. You're not going to die. Go get your mom. Meanwhile, on the inside, I was like, oh my God, she's going to die. She's going to die. So it fired a second time. It charged a third time, but didn't fire. And she was fine. So after that, Kayla retired again. And so this brings out just a couple different issues that I think are good to talk about. One is sort of where we've been and sort of where we've come to, because people really thought I was pretty crazy letting her play, and I may have been in that category too. So Kayla, how did it go? Kayla, she did great. Today is her birthday. It's her 36th birthday. And this is a picture of Kayla and her basketball team at her wedding, along with her coach and myself. And 15 years later, I'm really glad I made the decision. I'm really glad she's not dead. I'm glad, personally, that this shared decision-making approach is becoming more accepted and more of a standard of care, because I think that Kayla's life has been better off for having played and having continued to be active. And I personally would just like to really thank Mike Ackerman for encouraging me to see things sort of from a different perspective and supporting me in doing what I thought was right, agreeing to be on the witness stand if what I did was wrong, and thank Kayla for going through this, and her family for going through this journey with me, and really, I think, making me a better sports medicine physician and probably person. And so that's, I don't know if you guys have any thoughts. It's not all that controversial, but certainly, and go ahead.
So two, number one, when you said and then she met Mike Ackerman, I'm disappointed you didn't say and then she met me. Because when I was a first-year cardiology fellow, was that January of 2006, and I remember meeting her at that time and when she was getting her echocardiogram, and she really is a fabulous person if you guys ever get the chance to meet her. I think also just what's really great about this case is just, this was a dozen years ago, 15 years ago.
15 years.
The fact that what the sports medicine community and sports cardiology community were like then versus now, I think we all have a different opinion now versus then. So I really commend you, Mike, and everyone was involved in her care to allow her to do that at that time. I really sort of at the forefront of things.
I was really shocked that the University of Washington allowed me to make that decision. I thought it was going to be done right there. And maybe would have preferred it that way, and could have saved me some sleepless nights. But yeah.
Hi, John Dresner from Seattle. Kim, this is such a great case to reflect on, and I remember the journey a little bit too, and certainly not having any profound conclusions along the way. So your courage walking this journey with her is very commendable. This brings up a question that I want to ask the panel here that I wanted to ask through a couple of the different presentations, and it's about the athletes who do return with an ICD. And sometimes when we've talked about, okay, let's say we do screening, we diagnose someone with definitive long QT syndrome who's never had an event, or CPVT, they've never really had, or well, CPVT would be different, but let's say long QT, they've never had an event. They're clearly in a risk factor category, whatever. They get an ICD, not to return to sport, but just for life and risk. They do return to sport. And I think for a while, I always thought, okay, this is someone, we don't really know if they'd ever had of an event. When we identify them, they're at risk, but we don't know for sure that they would actually go on to have an event with time. They've had an intervention that we think lowers their risk, and they return to play. And part of my thought process is, okay, if you return to play and you have an event, you're done. You've now proven you truly are in that high-risk category of, I'm going to have VFib arrest or VT arrest during exercise, and now maybe you really shouldn't be doing that despite the fact that you have an ICD. You've proven that you are one of the people who are going to go on to have an event. Does that person now and today sort of fall into a different risk category? Kayla chose to retire, which is different. If you look at the guidelines, I think currently say 3-month window of no event. Well, they've spent 20 years with only one event. 3 months is sort of arbitrary. What is it? Should we be saying 3-month window and go back to play if you're okay, or if they have an event and prove they're higher risk, or should they be done?
So it's a great question, and I guess I can speak from maybe fortunately or unfortunately a little bit of personal experience with this, and I think it actually goes in two very different directions. So when the athlete has their event with the defibrillator, they self-declare in one of two very, very different ways. They say, you know what, that wasn't that bad. This defibrillator saved my life, and if that's going to happen every year or two, I'm loving what I'm doing, no big deal. And I actually think that at that point, they now really understand the informed consent process because they know what they're facing. The second, and I suspect that this was Kayla's experience, was that it happens. They, for the first time, appreciate the gravity of the situation in a way they never have before, and they say, this sports stuff is not worth it, I'm done. But again, going back to this concept we've talked about over and over the last 48 hours, the more people truly understand the risks and benefits of their decisions, the better off they are at making those decisions, and having an IC discharge is one important step in that informed consent process.
Well, I have to be the odd one out, clearly. I must admit that I would have lost my bottle. We've had one aborted sudden cardiac death, and she's shown herself again. And we know that one of the greatest predictors of risk is aborted sudden cardiac death. The problem with all of these conditions, and the reason why they seem to be benign, is because the event rate is just so low. Even if you look at Mike Ackerman's study, it's only 625 person years. That's not powered to show that long QT is dangerous or not, because the event rate is 0.2% per annum. So I must admit that whereas I am fully in touch with all of you in terms of autonomy, and that's the thing I battle with in Europe, because we're the only people that do say autonomy is so important compared to some of the other countries that we have to debate with. I think I would have probably been relieved had she retired like she did at this point.
I think the athlete who has an ICD shock is in a lot of ways not that different than anybody else who gets an ICD shock, because now they're starting to think about their disease in a different way. And I think for the athlete, one of the things you have to talk to them about is, let's say they decide to give up sport, it doesn't mean that they're never going to get shocked in the future just because they've stopped doing sports. They still have whatever their underlying disorder is. They're still going to have that risk again in the future. So I would never tell someone stop doing sports because you're never going to get shocked again. It just, yet again, it requires a lot of counseling and discussion at that point. I'll say that we have a lot of patients who, whenever they get their first ICD shock, athlete or not, a lot of them have a lot of psychological issues associated with it. Sometimes we'll have them see one of our psychiatrists to talk it over, because it really is a life-changing experience for a lot of them.
One of the really interesting things about this case in particular was, there's this distinction between recreational playing and playing in a more competitive setting. And I kind of thought that was like, well, I'm not sure that I really buy that. I think Mike sort of mentioned that yesterday. When we interrogated her device, she had had an abnormal rhythm one other time. It had been the week before when she was at Washington State. I see the Washington State team physician here. And it had self-terminated. And so over the year and a half that she was playing, the only times that she had abnormal rhythms had been during games. And she's not had a shock since then. The other thing that was really nice about this is that our home cardiologist disagreed with the opinion, but has still continued to be a great partner in taking care of her and helping us out. And so it was very collaborative all the way around. And it's not always that way. It certainly wasn't when I called the experts. And so I've always appreciated that sense of collaboration as well.
Since no one else is at the microphone for the moment, fabulous discussion, and just to reflect a little bit on the shared decision-making model, because I totally believe in it. But there's also a flip side to that I think we do, certainly within the sports medicine world, as we help athletes realize or come to a decision, or as physicians flavor the shared decision-making counseling and discussion in a way that hopefully brings them to a place where they understand that competitive sports aren't forever. And for lots of athletes, we help them transition, whether or not they're a high school athlete with a season-ending injury and they would never go on to play college sports, or they're a college athlete who's discovered to have a bad medical condition or has that season-ending or career-ending injury or just cumulative arthritis and can't go anymore. The middle-aged distance runner who finally has a meniscal tear who sets them over the edge and just can't compete anymore. And they have to transition from I'm a competitive athlete to I have to find an exercise outlet that is for fitness and do other things in life. And I think we can't forget that, it's not sport at all cost all the time, even in a shared decision-making model, and that there may be places where we want to help this person understand there are other options as well.
Thanks.
I just, it was sort of an interesting thing. Kayla got the decision to decide if she wanted to play or not to play, which was great. So she had this little extra, but when she really came down to it and was almost about to die, she didn't really want to die. And fortunately, she had the choice to then decide to quit, but not everyone's going to get that choice. So, I mean, gosh, we have the knowledge. Did she really have the knowledge of what it was like to be on death's bed, really? So it's another psychological thing to think about.
Yeah, I don't, the opinion at the time was that this had been sort of a once-in-a-lifetime sort of thing. She didn't have a diagnosis. She was idiopathic, sort of, and it's like, the sun and the moon and whatever were just malaligned, and this happened once. And it was always my intention that if it ever happened again, that she was done. And I was glad that she was of the same mind, so that, if she wanted to come back after gone, I would have struggled with that as well. But yeah, the other thing is adolescents always think that they are bulletproof and it can never happen to them, so yeah.
I think one thing, when you have an athlete either return to competitive play or just do a pickup game of basketball, that if they have a defibrillator, and I had one patient, he went back to just doing pickup basketball, which sounded a little bit competitive. He had an event, he got a shock, he got shocked right away, and when he came to the ER, they brought him to the ER, and I went down there. His heart, he was fine, he was in sinus, but the thing it was his head. He smashed his head because he was running and he went down, and he wound up getting a head CT, and his concern was more his head. So I think if we're going to send them back, they need to know that they could wind up falling, hitting their head, that there's potential that they could hurt themselves. And he turned out fine, and the head CT was fine, but just to know that in the process, even if the device rescues them, they could get into a situation where they can hurt themselves still.
Yeah, and I think that's when we were in our challenging cases, talking about having people go back to sports where if they become unconscious, that they're at risk. Like if you're playing football and you become unconscious, you can get killed. If you're rowing, you can drown, and so those are always considerations that have to go into this. Yes, Sunday?
I think the psychology goes both ways, and the decision can change over time. Having been part of a difficult decision with Dr. Ackerman, my athlete was incredibly mad at me for a while because I made her sit out while we worked on this, and it really affected her psychologically after that for a long time. And finally, near the end, we became closer again. But I think that they also grow over time, and we have to give them the opportunity to mature and maybe change their mind later. And so I find myself asking, and this is going to seem really odd to say in our role, but is it our job to make sure they don't die 100%? Like, they're all going to die of something. Or do we provide them with the information they need to make a good decision at that time and then reassess that decision as they mature? I don't know the answer, but I think it's interesting that we take it upon ourselves to 100% say we have to wrap them in a bubble and make sure they don't die, because I don't think that's possible.
Yeah, I think that's a great point. And when you're disqualifying somebody from participation, it is never an easy decision, even if it's very clear cut. And the thing that makes some of these cardiac decisions harder is because the risk is unknown. When people have had a lot of concussions or have different findings, a lot of time it's usually gray, but it's much easier when it's more black and white.
And absolutely, and I think that's exactly what I was just thinking. And what I'm hearing from everyone speaking over the past couple of days is that this concept of shared decision-making largely involves the fact that we don't really know what the risk is. I think that's exactly what a number of you have said. I don't think any of us, if we really feel like an adolescent particularly is seriously at risk of death, we sort of try to bargain with them and make them understand what that means. They don't understand what that means. They just don't. So I think being very paternal, or whatever the right word is, in that situation is totally appropriate, and just say no. But I think that's the whole point, though, is that we're identifying things that carry some degree of risk, but that risk may actually be extremely low. And I think in that situation, then it is a hard decision because we don't know what it is. And I'm not sure if that is an accurate summary with what I've heard for the past 2 days. If not, suggest otherwise, but it seems like that's the black box. It's not that we're really bargaining with people about whether or not it's more important to play high school football or college football or to live to be married or something like that.
Yeah. I think in reality, the riskiest thing most of these kids will do is get in a car and drive to and from practice or game. But that may not be true with some of these kids with cardiac conditions.
If I could just shift the conversation for a second. So you described noting that her ICD had gone off. You guys went into a hallway. You tried to calm her. From a practical standpoint, did you guys have like a game plan? Like if it went off,
Yeah.
what were you going to do?
So the athletic trainer who was on the other side of her had an AED in her hand. We were walking her through the hall to where we were meeting the ambulance.
Yes, okay. And then did it prompt any or what kind of further workup at that point? Were you looking for anything that was modifiable other than just assuming that this was her underlying cardiac whatever versus something else that may be putting her at additional risk? And then did that later do more diagnostics in terms of did she actually have long QT, et cetera?
She still remains without a diagnosis. She has had genetic testing that is negative, and it didn't really prompt any additional workup. She was sort of under continuous sort of scrutiny and care.
Kind of worth saying something that maybe is obvious, but we've been dancing around this point, and it really refers to the role of the physician in the shared decision-making model. And I think it's easy to step back and see the physician's role as merely being an educator that presents information and allows the patient and family to make a decision, but that would be selling our role short. Our role is not to be wet noodles, but to come to the decision equipped with an opinion. And that opinion, again, is based on data, based on what we know about risk, but more importantly, what we know about uncertainty. And so we do end up providing recommendations. And there are many situations where the data are compelling to recommend that an athlete no longer engage in competitive sport and avoid other physiologic stressors that approximate sport. And that's okay, that's our role. But there are just as many times where we are uncertain to the point where we don't think it's prohibitive. And I just want to make the point that going into these decisions with that lens, knowing your own opinion and being comfortable explaining that is really what this is all about.